Good morning, and I would like to thank Dr. Hussein and the committee for the kind invitation. It is always a pleasure to be with you in such a great meeting. My talk is about thyroid nodule in pediatrics, and I will be going over the epidemiology and clinical significance of thyroid nodule, and then shed some light on the differences between benign versus suspicious and malignant nodule, and then go over the guidelines of how to assess and manage thyroid nodule. So it is well known that thyroid nodules in children are less common than they are in adults. There are many different reports from different regions in the world showing a thyroid nodule to be less than 0.1% clinically detected to as high as 7% or 8% detected by ultrasound. Generally, it is much less common than we see in adults. And most of the thyroid nodule in pediatric are seen in older ages and adolescents rather than younger ages. However, there is a special clinical significance for thyroid nodule for the facts that, number one, they are remarkably more malignant than adults, almost 5 times the risk of malignancy. The second factor is pediatric patients tend to present rather late during the course of the disease than early. And the third fact is the epidemiological data that shows the increased rate of thyroid cancer in children over time. Here's an example from the surveillance epidemiology and end result program showing that the annual percent changes in female has increased by 4.5% between the years of 2000 and 2018, as you can see in the blue line. Even though there was some decline after that, however, it did not reach statistical significance. Similarly, in males, there was 3.7% increase straight from the year of 2000 to 2022 in the green line. Similar data was actually published from different areas. I'm showing example here from Saudi Arabia, where the trend of thyroid cancer in children and adolescents was analyzed over a period of 23 years. And they found that there was a 3-fold increase between 1994 and 2017. And the highest rates in their cohort was in female patients between the age of 15 and 16. So there is a linear increase in thyroid cancer. I am not sure if there has been any data to show whether or not the risk of thyroid nodule has been increasing similarly to that or not. Nonetheless, we need to keep in mind that whenever we detect thyroid nodule in children, we have to approach it much more carefully than done in adult medicine. So how do thyroid nodule present? The vast majority are basically asymptomatic, and they're discovered either incidentally during physical exam of the neck or because of doing neck ultrasound for a different reason and then find thyroid nodule as part of the report. Thyromegaly can be seen if the nodule is rather large, and that can be one of the earlier presentation. In rare scenarios, if the nodule is secondary to toxic nodule, then patient might present with hyperthyroidism. Similarly, in very few scenarios, there might be an initial presentation of pressure effects such as hoarseness or dysphagia. Because of the fundamental change or difference, I would say, in prognosis and the need to different things between benign nodule versus suspicious or malignant, it is essential and crucial that we should be able to differentiate between the different type of nodule so that we can determine the scope of intervention and the type of follow-up. In order to do that, we need to collect as much data as possible from the medical history, the physical exam, the imaging, and of course, finally, the pathology from the aspiration samples. So what are the factors that we need to consider as a risk factors in the medical history that should increase your index of suspicion for malignant rather than benign nodule? Number one, males patient, especially those are younger than 10 years of age. If nodule is increasing rapidly in size between the visits, if there is past medical history or family history of cancer, if there is previous history of either accidental radiation, such as Chernobyl accident, or even radiation because of medical reasons, such as radiotherapy, and syndrome that are known to be a tumor predisposing syndrome, such as mutation in DICER1 gene, MEN2, Carney complex, McCune-Albright, and so forth. So it is important to know if your patient has one or more of these factors, then you're more likely dealing with a less favorable nodule than the opposite. What about the clinical risk factor, the factor that you find on clinical exam that should increase your index of suspicion? If the nodule is palpable, most likely, not necessarily all the time, it is an indication of worse prognosis. In another meaning, not all large nodules are more pathological than all small nodules, but there is some sort of correlation between larger nodules and malignancy. Palpable lymph nodes in level 3 and level 4, those are the middle jugular and lower jugular, is a poor prognostic findings. Compression signs like hoarseness and dysphagia is more concerning. And if the nodule, of course, is firm on palpation or fixed, immobile, such like any other lymph node or mass you might feel, that increases the risk and suspicion of malignancy. Then we come to the radiological indications, and here I'm talking mainly about thyroid ultrasound. There are multiple categories, out of which 5 categories are in particular important. So my advice to you, whenever you do thyroid ultrasound, you want to make sure from the radiologist that they include those main categories in the description of the nodule. So the composition is extremely important because cystic or cystic spongiform is much more favorable than mixed cystic or solid. Echogenicity is another important factor, as anechoic is more benign than hyperechoic, isoechoic, or hypoechoic. The wider than tall shape is more favorable than taller than wide. Smooth and regular margin definitely is a more benign finding than irregular margins or signs of extrathyroid extension. The lack of microcalcification is a favorable finding, opposite to the presence of either macrocalcification or REM calcification or microcalcification. And peripheral vascularity is better than intranodular vascularity. Those are important elements that should be in the ultrasound report. And the American College of Radiology came up with the TIRADS classification, Thyroid Imaging Reporting and Data System, in which they have taken those 5 categories and came up with a grading system for the different findings. They add all the points together and they come up with a classification between 1 and 5 that I will explain to you later on. And it tells you what is the risk of basically dealing with suspicious, malignant versus benign nodule. And then the final step in your approach is, of course, looking at the pathological findings. And here we have the Bethesda system with 6 levels or 6 classes of findings. The higher scores or higher class indicate more risk of malignancy and more need for surgery, as I will explain later on. So once you collect the data of medical history, your physical finding, the ultrasound, and of course, the pathology will be the final word. You can tell if most of the findings you have are favorable, you're most likely dealing with benign nodule, versus if the findings are unfavorable, it is most likely indicating of a malignant nodule. So let's put that in a clinical context. So once you have a patient with thyroid nodule that is either detected by clinical exam or imaging, if not imaging, then you need to do thyroid function test and thyroid ultrasound. If it's already detected incidentally by ultrasound, you want to make sure you have the full detailed ultrasound report. Why do we need to do thyroid function test on all thyroid nodule? Because if TSH is suppressed, you need to explore the possibility of toxic nodule, which requires a simple surgical treatment, which is lobectomy of the affected side of the thyroid, and the case is solved. If the TSH is normal, or even if it's elevated, then the toxic nodule possibility is no longer there. Then we need to look at the ultrasound findings. And as I said, from the finding of ultrasound, you need to decide whether this nodule need to be biopsied or not. And here I will take you back to the Thyroid's classification. This classification system is for adult patient. And once again, 5 categories, scoring system. If the points are 0 or 2, that's class 1 or 2. Biopsy or fine needle aspiration is not indicated and patients can be followed. While if the points are 3 and the class is 3, then FNA is indicated. If the size is 2.5 centimeter or more, or patient need to be followed for a smaller size. And then the higher the class, the smaller the size that indicates FNA, as you can see. So when we come to Thyroid's 5, if the nodule is 1 centimeter or more, then FNA becomes indicated. And if it's half centimeter or more, then the patient need to be followed. Now, those cutoff sizes are for adult patients. As you know, pediatric patients have smaller size thyroids. So how applicable is Thyroid's classification strictly to pediatric patients? This study here looked at 404 nodule in 314 patients, including a total of 77 cases of confirmed thyroid cancer. And they found that retroactively, if the Thyroid's classification applied with the size cutoff to those patients, they would have missed 22% of those 77 cases of thyroid cancer. Similarly, meta-analysis of 8 studies or 8 articles, more than 1,000 thyroid nodule, showed very similar findings. If the Thyroid's classification applied strictly in adults to children, we will probably miss 22% of thyroid cancer. And that is why the American Thyroid Association has emphasized that not only the size alone that should determine the FNA, but also the ultrasound characteristics and the clinical context of your patients. So once the FNA is done, results will be either benign, suspicious, or malignant. And here we come to the treatment. For benign nodule, observation is usually the option of choice. However, surgery sometimes in the form of lobectomy can be done for large nodules because of either compressive symptoms or because of cosmetic, especially in female patients. Lobectomy is the treatment for autonomous nodule. And if the pathology is showing thyroid cancer, then the treatment can be in the form of either total thyroidectomy, near total, or recently actually lobectomy has been one of the options with the availability of genetic testing. And I'm sure the speaker of the next session will elaborate more on that. So this is the system that I have showed you before. Once again, we have 6 categories. So number 1 is non-diagnostic, simply need to be repeated. If it's class 2, clinical follow-up is all what we need to do. If it's class 3, FNA can be repeated in 3 to 6 months. from class 4 to class 6, surgery becomes one of the options at different scope between lobectomy, near total thyroidectomy, or total thyroidectomy with neck dissection. Once again, that's probably going to be covered in the thyroid cancer lecture. So what does the guideline show? Well, the American Thyroid Association have released guidelines from 2015. I haven't seen updated version in pediatric patients, but it's still applicable. And it says clearly, whenever you have patient with suspicious nodule. So now this is patient with thyroid nodule. The ultrasound finding is suspicious. So they're also recommending that you need to do thyroid function test initially. If the TSH is suppressed, you do thyroid scan. If it is toxic nodule, patient needs surgery. If it is not toxic nodule, then this patient needs to have FNA. So that's if the TSH is suppressed. The other scenario, TSH is not suppressed, then this patient needs to have FNA. Once again, we're talking about suspicious nodule. If the findings are benign, patient can be followed in 6 to 12 months by doing ultrasound. If it is stable, subsequent follow-up can be done every 1 to 2 years. But if the nodule is growing, then the patient needs to have another FNA and consideration of surgery. So that's one extreme. The other extreme, if it is benign or suspicious, patient need to have surgery. Again, the scope of that will probably be covered by the thyroid cancer session. And if the FNA findings is inadequate or non-diagnostic, then patient need to have another ultrasound and FNA in about 3 to 6 months to decide the subsequent step. So in summary, thyroid nodule in children are less common than they are in adults, but the risk of malignancy is significantly higher. Thyroid function test and thyroid ultrasounds are both indicated in all cases of thyroid nodule. Proper clinical, imaging, and pathological assessment are essential to determine the best approach. Thank you very much.